Very good afternoon. I'm Narayana. Yeah, I'm going to talk about the acoustic signal analysis for healthcare using AI. What you are seeing on the right is a sound signal and how that is actually the energy of the sound distributed in the frequency domain. So it actually carries a very important information. So the background is, there's a lot of research, and also there are many medical device companies working on non-invasive monitoring methods based on body acoustics to investigate wide range of conditions like cardiovascular diseases, respiratory conditions, and so on. Essentially, the advances in technology, like be it the sensing technology or the computational resources, and also the AI and ML, is really helping in accelerating these kind of development. So if you just look at it, you may already be knowing this, but say for example, lung sounds, there is an abnormal lung sound and a normal lung sound. And if you go further down, you have wheezes, crackles, and in wheezes you have monophonic wheezes, polyphonic wheezes, fine crackles, coarse crackles, and so on kind of a thing. When you try to listen to them, they do actually, all of them, you listen differently. I mean, they are different sounds. So essentially what does that mean is they carry different characteristics. Similarly, there are normal heart sounds and abnormal heart sounds. More interestingly, voice also carries a lot of information. For example, for chronic obstructive pulmonary disease and the bronchial asthma, it actually has adverse effects on the voice. Similarly, Carnegie Mellon University has done a lot of research, and they have identified that in the case of COVID-19, the respiratory system gets affected, and the vocal folds oscillations are very asynchronous, and actually it has a restricted functionality, which actually produces a different kind of sound. So what we are working on at Salcit is actually using the cough as a biomarker in identifying the underlying respiratory conditions. So cough is an expulsion of air to clear the airways. This is the most important slide. I mean, when we ask a healthy person to give a cough, the glottal gets opened and slowly it gets narrowed down. So you'll see a strong expulsion followed by, when the glottal gets narrowed down, it's a small bout which the sound ends. But whereas when you ask someone with an obstructive lung disorder to give a cough, he has energy to breathe in, but the problem, because of the obstruction, he is not able to breathe out. It is actually taking slightly longer duration, and also it is multifolded. Similarly, the moment you have a lot of mucus accumulated, you see a different pattern on the sound. But when you look at somebody with an interstitial lung disease, he has a problem in breathing in the air. He does not have enough energy to expel. So when he is giving the sound, it is actually coming out to be weak cough with repetitive bouts in nature. So essentially, this is really how we have established the association of cough sounds to the different respiratory conditions. So the moment you give this kind of a data to a machine, it learns these patterns, and once we actually use it in the real time, it decodes that pattern and try to see which condition it is closely matching on. So basically, the methods to collect these are, you can use the mobile phone just to record the sounds, or you can also use an external microphone. When it comes to capturing the breath sounds, you can use something like an electronic stethoscope, or even you have a chest jacket, something of that sort. So this is really what our system is all about. So we use cough as a biomarker. Along with that, we also use a subset of St. George respiratory questionnaires as an input to our device. And what you are seeing on the right side is the output. We try to identify whether there is any underlying respiratory problem, I mean normal versus abnormal. And if there is an abnormality, is it attributed to the obstruction in the airways, or is it more related to the lung expansion problem? So here we provide an output which is functionally equivalent to a spirometry. And we also provide some rich amount of data, like how many wet coughs are there, how many dry coughs are there, and so on, which will really help us to have a longitudinal view of the patient. Similarly, we are adding conditions to detect likely presence of diseases like pulmonary tuberculosis, asthma, COPD, bronchitis. I mean, right now we are working with Dr. Balmukesh and Dr. Sujit in completing the validation, a large-scale validation at CMC Vellore. Essentially, the device is meant to be used for screening. So, as the patient walks into a rural health center, we can use SWASA to identify the underlying respiratory problem. Based on that, the patient can be referred to a tertiary care hospital or to a pulmonologist. And it can also be used as a differential diagnosis. As a physician, I'm using this information along with the other information I have in making sure that maybe there is something wrong here, so that I can actually refer the patient for an X-ray or something. I mean, it reinforces my understanding. And more importantly, when it comes to like chronic disease like COPD, it can be also used to do a disease management. So as the patient is going through the treatment, how the sound characteristics are getting changed. So we'll be able to understand how effective the treatment is. So when it comes to challenges, it's completely new technology, and it's a new way of kind of screening and diagnosis. So acceptance is definitely a bigger problem, and we understood this pretty much in the beginning. And what we are doing is that we started providing an output which is functionally equivalent to a spirometry instead of directly getting into diagnosing a COPD or a tuberculosis. Slowly we are adding that functionality. And obviously the second one is really the biggest challenge, and we have no predicate because this is the first technology which is coming out. So without any predicate, getting any kind of a regulatory approval is really going to be very challenging. The only way to solve this problem is you prove the science, have publications, and do a lot of validations, and then that's how you get the. So of course there are other challenges, like the technology is limited by quality data sets. Of course you need to focus on annotated data, and also like we heard like for example deep learning, machine learning. Interestingly, we are using a hybrid architecture. It has both deep learning and as well as the machine learning. So the machine has capability to learn some of the features which we are actually giving it. And it's not representative of the wider population. We are doing multi-site validations. Obviously, validations at CMC Vellore, there is an advantage because you have distribution from different geographies. And as Raghu mentioned yesterday, inappropriate use of statistical, it's a balance you need to have in terms of the data versus the cost. That's basically what I have.